that SNHD is building, as well as the ISOQ isolation center for the homeless. Do you guys have dates when either of those will be open?
So this is Jeff Quinn with Southern Nevada Health District. So we're in progress of identifying the vendor to set up the isolation quarantine facility here at Southern Nevada Health District. That process is still in process. Now, Cashman, the Cashman field location was set to open up several times. And I think the target date for that facility opening up will be on Monday of next week.
Okay, so I've muted everyone. If you need to ask a question, please use the raise your hand feature. So if you're on the computer, that'll be under your participants list. If you're on the phone, hit *9. I have a question from Mary Hines here. She says, any indication of the curve of disease? Any signs that it is leveling off?
I guess I can take that question. So we do know that we are still, the number of cases per day is increasing, and it seems like it's still increasing exponentially. There may be signs that the rate of, like the curve, the rate of the curve is decreasing slightly. So we're still in exponential growth, but it's possible that the slope of that exponential curve has decreased slightly. I know that's a little bit, it's a little bit of a mouthful, but basically we're seeing some early signs that potentially the school and business closures have had some impact. It's a little bit early to tell. I think we're gonna have to do a rigorous analysis, and we've got several people here who are working on that.
Okay, I have a question from someone, phone number ending in 7440.
Thanks, that's Ken Ritter at the Associated Press. I was asking on Wednesday about the materials being received, processed, and distributed at the convention center. Are you able at this time to tell us what's coming in, what's being distributed?
Yes, so it's a Las Vegas Convention and Visitors Authority. We received managed inventory from the Federal Strategic National Stockpile. So as that PPE comes in, it gets broken down and then coordinated through the Multi-Agency Coordination Center, our county EOC, for resource requests that have come in. So we fill those based on priority groups, and the priority groups are acute care hospitals, so the 18 large acute care hospitals that we have throughout the valley, our EMS providers, both private and the fire department EMS, law enforcement, and then other healthcare system partners. So as that PPE comes in, it gets broken down and distributed out. Generally, we have two SNHD facility or two SNHD preparedness people down there working with the National Guard and with Clark County to actually break that down. I know that we received more inventory, our last bit of inventory that we received through managed inventory yesterday and today, and that right now is being distributed out to the recipients.
Our next question comes in the chat box from Miranda Wilson. How are you tallying deaths at this point and determining if a patient is a coronavirus victim? What's the involvement of the coroner's office in that process?
So we find out about deaths in two ways. One of them is if we are actively investigating a case and we know that a certain person has a positive laboratory test, and then we find out from the hospital that person is deceased, and that's one way we find out about it. We also find out through the coroner's office. So often they will know about deaths prior to us knowing about it, and so we receive communication from them as well. We also an additional way we find out about deaths is through death certificates, and there's often a time lag through that. Most of the time, we've already picked up those deaths, but we do find additional cases that way. There's some concern about people who die who haven't been tested, and the Council for State and Territorial Epidemiologists has released a case definition for basically people who you suspect may have had COVID symptoms and then died. And so we're trying to figure out how to incorporate that data as well. You know, what we don't want to do is really systematically undercount the number of deaths. So that is a challenge.
So also, this is Misty Robinson with the Office of Public Health Preparedness. The coroner, when they arrive at a death scene, if that person was at home, then they will be swabbing the decedent to process for COVID positive, or to figure out if they're COVID positive before they will do any type of autopsy or anything like that. So they have adjusted their protocols to account for that.
Our next question comes from Michelle Price.
Hi, I'm wondering, you know, with tests in such short supply, you generally have to have most, if not all, of the symptoms to get a test right now, but the statewide rate of positives is still about 11%. And I'm wondering if we think that's low and if we have any sense of how many false negatives there might be.
So I think our suspicion is that a greater percentage, our suspicion is that if you just tested everyone in the population, the percent of people who would test positive is likely lower than the estimate we're getting. And the reason being is the people who are being tested now are systematically people who are more likely to have symptoms. So they're more likely to have symptoms and more likely to have severe symptoms. A lot of the testing is happening at hospitals and also at clinics. So we know that people who are symptomatic are more likely to so someone who's symptomatic versus asymptomatic, who has the disease, the symptomatic person is more likely to have a positive test. It's difficult to know what the false negative rate is because the main source of testing are the tests we're doing, the PCR tests. Usually when you're trying to gauge false negatives or false positives, you're comparing the current test you're using with a gold standard. So for some example, some tests have a culture that you can do, and you assume that the culture is the gold standard. For this, everyone's pretty much using the PCR test. So the PCR is sort of the gold standard right now. So it makes it very difficult to assess, the rate of false positives and false negatives. We do know anecdotally that people during the course of their illness, they may be infected, but they may initially test negative and then later test positive. So we think that the sensitivity of the test depends on sort of the disease course, like how much virus they have in their body at a certain time. And so below a certain threshold, they may test negative even if they have infection. All these things are really difficult to parse out at this time.
Our next question comes from Cynthia from Telemundo. Can we talk about the recovery cases? What's the expectation on that? An increase?
Sorry, could you say that one more time?
Can we talk about the recovery cases? What's the expectation on that? An increase?
Oh, you mean do we expect the number of recovereds to increase over time? Yeah, I mean, so we are putting out that, I think we have given estimates of the percent or the numbers recovered. That's really based on a lot of different assumptions. I mean, at the end of the day, the people who recovered are basically the people who, the total number of people who had the illness, and then you subtract the number of deaths. I mean, in the long run, that's kind of what it is. So we know that the estimates of the mortality for this are probably something along the lines of 1% or less than 1%. So we would expect that everyone else would eventually be recovered or would fall into that recovered category. So we're trying to give sort of real-time estimates of that number, but at the end of the day, that is what you expect. You expect 99% or greater than 99% of people to have recovered. Now that it's a little bit difficult because we're not testing every single person. We don't know 100% of the people who have the disease, but based on estimates from different countries, we suspect that the death rate is probably 1% or less than 1% in the population. So we'd expect that somewhere around order of 99% of cases are going to recover.
Okay, we're taking a question now from the phone number ending in 2962.
Hi, it's Dana Gentry from the Nevada Current. I was wondering, have you done anything to determine deaths by ethnicity?
Yeah, so as you know, that as the number of cases increase, it becomes difficult to systematically collect all this information for every single case. We are prioritizing people who are hospitalized and people who die. So we do have that information. I'm pretty sure we're going to put out that information at some time. I don't have the information at the tip of my fingers, but I think, you know, I think it's reasonable that we're going to have those conversations about releasing that information.
Mary Hines asks, what are the signs that the curve is flattening? What does this mean? Please elaborate.
So I don't want to speak too far ahead of myself here, because I think I want to make sure that we have like the rigorous analysis to back up what we're saying. So I do know that people in our office, our Office of Epidemiology and Disease Surveillance, are working on sort of determining the effects of some of the interventions that have happened so far. But I don't want to speak too much about it now, because I don't want to give sort of false information or preliminary information, if that's okay with everybody.
Michelle Rindles asks, the latest report still indicates we do not know the race or ethnicity of 41% of the cases in Clark County. What steps might the health district be taking to gather that data and better identify any race or ethnicity disparities?
So during the course of a usual disease investigation, under ordinary circumstances with a disease that's with basically other diseases that we investigate, if we hear about a case or we are reported a positive lab or something like that, we reach out to that individual. We do a very detailed interview. We gather information at that time. We also review medical records and parse that information through the medical records if we don't talk to the person individually. This becomes very difficult when we start to see, you know, hundreds of cases being reported in a single day. We have about 50 people currently who are working on doing these investigations, and each of these individual calls can take a couple hours, 2 or 3 hours to do and to identify contacts and stuff. So just based on the math, you know, we don't really have enough staff at this time to do these detailed phone interviews. What we're trying to do is we're trying to shift our strategy to rely on more electronic means of communication. So people who are not in this like really high priority group, so people who, for example, haven't died or aren't hospitalized or don't fall into several other priority groups, and we're trying to work on electronic notifications. So notifying them via text or via email, and then collecting some of this other information. Now, just because of the sheer number of cases, we at the end of this, we probably aren't gonna, I mean, we aren't gonna have complete data. And we see this across the country, you know, with the CDC, they reported, for example, on hospitalizations and the risk factors associated with those hospitalizations. And we see that they were only reporting on 5% of the total number of cases. So this is an issue really across the entire country. Some areas have chosen to stop contact investigations altogether, and they're just basically surveilling this passively through laboratory reports. So throughout all this, we have to really prioritize our limited resources. So as much as we want perfect data, I think right now the most actionable information we want is information about close contacts of people. So the more people we identify who have a positive test, the more we identify close contacts, the more we can recommend those close contacts a quarantine at home if they fall into the appropriate risk category, because then those are people who aren't spreading the disease potentially to others if they do develop the disease.
Let's go back to another phone question. Caller ending in 6314.
Hi, this is Kendall Kim from Channel 3. I have a couple of questions. The first one being, I know we've discussed the potential flattening of that curve and the need for more rigorous analysis, as you said. Yesterday, though, we cited with UMC the, I guess, peak date, 17th through 19th, so going into a week from today. Is that still what we're looking towards in the future? Like, is that still a peak date?
So the estimated peak date, I think that you're referring to, is based on the models put out by the Institute for Health Metrics and Evaluation in Seattle. And I know this has been a very influential model. It's something that, as I understand, it's influencing decisions at the national level. You know, this is a very niche area of epidemiology, and there are a lot of people working on this, and they have a lot of different models. And these models are good for planning purposes, as far as determining estimates of the peak and allocating resources and things like that. But we really have no way of knowing which model is going to be the most accurate. Some other types of models that have been put out projected peaks being much later, at a much later date. And so at this time, I think we just have to sort of wait and see which model ends up being correct. So it'd be nice to hear that our peak comes sooner rather than later.
Yeah, I have a second question as well. I know that there's been the study of antibodies of recovered cases in other cities throughout the nation. Is there anything like that going on here?
I can't speak on that topic. I don't know what research is being done outside the health district on that topic. You know, this is an area that I know that a lot of people are interested in, looking at the antibodies after recovery. I think we still don't really know, even if people who develop antibodies, if they have, if that provides long-term immunity against repeat infection. So I think it's a little early to speculate.
We have a few reporters with follow-up questions, but first we're going to go with those who have not yet had their chance to ask. From Jackie Kostek, can you talk about hospital capacity right now and expectations for where that capacity will be when we hit our peak? Also, any update on when you expect to hit our peak?
Jeff, do you want to speak on hospital capacity?
So with the hospitals, interesting enough, right now, a lot of our emergency departments are not seeing the huge surge that we're seeing in other parts of the country. Now, while last week and weeks prior to this, they were extremely busy with the number of cases that they were seeing of potential COVID patients. We are still in influenza season, so a lot of our cases may still be what's currently circulating in the community. However, right now we're kind of in a working management of those patients. A lot of the healthcare facilities have implemented triaging and set up in their parking lots triage areas where they can screen the large number of individuals that were coming in. And that is still a wait and see. With this particular virus, it's very unknown. We, could be seeing future dates where we have surges of patients flocking to our healthcare facilities, and we need to be prepared to manage that surge as it comes in.
I think I can comment again about the peak and when will that happen. One of the things that makes these sort of estimations complicated is that you're relying on past data to project something in the future. And a lot of times when we receive this information on these sort of models, we change our behaviors. So some of these models can estimate a peak at a certain time. But if we all take measures such as, Governor Sisolak ordered the school closures and the business closures, non-essential business closures. And that has the effect of not only decreasing the height of that peak, but it pushes that peak out to a farther date. So it becomes difficult to know when we, for example, just say we get to that date estimated by the Institute for Health Metrics and Evaluation. If we reach that peak and it seems like the cases are still going up, but not as much, we don't really know if that model is inaccurate, or we don't know if our behaviors have changed conditions such that that peak is going to be at a later date. That's what makes it so complicated.
And another thing about the hospitals are reporting that there's a flattening number of patients coming in with COVID. So right now they're staying at level capacity, but we do expect that to go up.
Vanessa Murphy is asking, are you noticing clusters of positive cases? Are you keeping track of that, meaning the locations of those cases? Would that information be released? And can you identify 1 or 2 specific clusters for us?
So for every case, when we identify, if we have an index patient, so the person who originally tested positive, and we investigate that, we identify their contacts, and we monitor those contacts either through the phone or through electronic means. And when we find out those people have symptoms, then we will promote testing, and we identify people who now have the infection. And so we are seeing, throughout the valley, we've seen a lot of cases where there are family members, for example, of the index case who then becomes positive. And this is to be expected. We know that the family members are at the highest risk of developing the infection. I think the state also put out information recently. I saw it in the news about cases associated with nursing homes and long-term or skilled nursing facilities. And this is another situation that we're monitoring. There's so many individual cases and there's so many contacts that it's not really feasible to put out this information all the time in real time. I think a lot of this stuff, a lot of the information we're putting out has to be, the analysis has to be done sort of ahead of time. And once you build that analysis, then it becomes easier to maintain it. So I think as time goes on, we'll be putting out more and more information, but it's sort of an incremental process.
The Reno Gazette-Journal asks, in observing COVID-19's behavior, are you seeing similarities to past pandemics that included a second wave of cases? Is that something that we can expect in Southern Nevada?
I think that's a question that we can't answer just based on our case numbers. I think that question has to do with more of what we think about this disease. This is a coronavirus. It belongs to a large family of coronaviruses that are mostly seasonal. So it wouldn't be unexpected, I guess, if this if this follows more of a seasonal pattern. But at this point, we just don't know. The 2 coronaviruses that are most similar to this, SARS and MERS, well, in the case of SARS was basically controlled and eliminated. And so we never got to see the answer to that question of whether it demonstrated seasonality. But I think based on other coronaviruses, I wouldn't be surprised.
We're going to go back to some of our follow-ups. This is for caller ending in 2962.
Hi, do you have any numbers on infections in nursing homes, skilled nursing facilities?
So nursing homes and skilled nursing facilities, those type of facilities are regulated by the state and not by Southern Nevada Health District. So that information would have to come from the state. I did see an article just recently where that information was requested of the state, and it was published in a news article. So I think the state is putting out that information.
This question is for Jeff from Ken Ritter at AP, following up. What has come in? Test kits, PPE masks, gowns, ventilators, sanitizers, and can you quantify received items?
Yeah, so the federal managed inventory is somewhat limited in what items we receive. N95 masks, surgical masks, gowns, and other face shields, the clear plastic face shields. Other items that are not included as part of the managed inventory would be goggles. We have received some limited hand sanitizer, but the primary PPE, the gowns and the N95 mask and surgical masks is generally what's in the inventory shipments that we've received. Now we have also, through the generosity of a lot of our Southern Nevada business partners, they have donated an amount of PPE and other items. We did receive on loans through the state of California 50 ventilators, but we also have a request from our acute care hospitals for over 600 ventilators. So really working through our multi-agency coordination center, we'll take resources like that and be able to divvy up those limited resources as we get them. We also had 100 gallons of hand sanitizer donated, which was one of the unusual items that we received. But working with one of our local bottling companies, we're able to put it in unit of use quantities so that we could distribute that out. With that, with the generosity of the Sands Corporation, the Wynn Corporation, a lot of the items that they have donated are currently in the process of being broken down and distributed out. So whereas some of our healthcare facilities, rehab hospitals, and individuals that have not received any of the managed inventory from previous shipments are likely to get some quantity at this point. Now, through the resource requests that have been submitted to the Multi-Agency Coordination Center, pretty much it's still a fraction of what we've actually received and what we're able to distribute out. So nobody has gotten the full amount that they have requested. They get a fraction of that, and it really is important to recognize that. So still purchasing PPE through commercial means, if we can get it. There have been other jurisdictions as well that have purchased PPE that may also be purchased by healthcare providers that as they need them. Those are some of the smaller mom and pop type provider groups where they're maybe not affiliated with the larger acute care hospitals, but an individual private practice provider could go that option and go that route. But I do know that from the inventory that was donated from either the Governor's Supply, the Sands, the Wynn, those items will be offered up to some of the smaller healthcare providers in the community as soon as Monday and Tuesday of next week.
In addition to that, the Multi-Agency Coordination Center is receiving a number of vendors that would like to sell items to us. The Multi-Agency Coordination Center is vetting those vendors to ensure that they are providing quality PPE and items that we need. So that process is ongoing as well.
Miranda Wilson asks, the health district just received $503,000 in grant money through the CARES Act. Do you know what that money will be used for?
I can't say what that specific money will be used for, but generally when we receive either federal funds or grant funds, there's a very specific use on how that money can be spent. Generally, it might be to cover costs that the Southern Nevada Health District and other community partners have already incurred in the response to COVID-19, and those dollars generally go very, very fast. It's only a fraction of the amount of money that's being spent to protect the public health in the community. So we could always use more money, and that is really what we are working through, not only the governor's office and the state and local government, but with our congressmen and senators to get more allocation of funding and resources for the state of Nevada.
Michelle Rendles asks, Congressman Mark Amodei announced a week ago that Nevada was expected to receive 15 Abbott ID Now rapid testing platforms. Have any of those arrived in Southern Nevada, and where would those be deployed first? Would healthcare workers or any other group be prioritized for having access to rapid result testing?
So with resources like the Abbott testing machines, generally that type of instrumentation is a point of care type instrument. It's to assist healthcare providers with providing immediate benefits or treatment possibilities for the patients under their care. I know that some of those pieces of equipment have been received here in Southern Nevada, and they've been distributed out, and primarily where these locations are would be at an acute care facility.
Alexander Zapata from Univision is asking, can you please talk about the criteria you use to determine that someone is cured?
Sure. So the CDC has, they have basically, for determining the end of home isolation or end of isolation in a hospital setting, they have testing criteria and they have non-testing criteria. So testing criteria basically states that after a certain period of time, without fever or symptoms, they then test that individual and they perform repeat testing on a certain interval, and after 2 negative tests, then they're considered cleared. Because access to testing is difficult and we don't have as many tests as we would like, there's also a non-testing criteria that bases just on clinical symptoms. Now, when Southern Nevada Health District makes calculations regarding recovered, we're using different information. So if we have information on people's symptoms, then we factor that in. If we have information on hospital visits, for example, like when someone was discharged from a hospital, we make assumptions. For example, if someone's currently hospitalized for the disease, then we assume that they're not recovered. When they're released, we assume that there's a certain period of time, for example, about a week, where they may still have the illness and but are sort of on the road to recovery. So there are a lot of those different assumptions that are going into that number. Now, as far as I know, there hasn't been one standardized way to calculate this number across the country. So I think estimates you get from different states and different counties are going to have different methods, and they're not necessarily going to be completely comparable. I think this number you have to take with a grain of salt a little bit. We calculate it using a consistent methodology. So over time, you can compare our current numbers with our previous numbers. But if you start comparing, one county to another or one state to another, I think those results could be misleading.
Ann Truzolino is asking, when do you think schools will be reopened?
I don't know. I don't know the answer to that question. I think that's going to be a decision that's made at a higher level, and I think that's going to be made based on what we're seeing in Clark County in terms of the number of cases we're having and whether those cases seem to be going up or down.
Yeah, that question's really for the Clark County School District Superintendent.
Mary Hines has a follow-up from earlier. She's asking, what about geographic clusters like downtown or Sun City? And she's also asking, do you envision a shortage of ventilators?
So as far as geographic clusters, as you see from our race ethnicity data, there's a lot of missing data. And so for every case we have, or for most of the cases we have, we do, or I don't know if it's most, but for a lot of the cases we do have certain addresses or zip codes associated with it. Now, sometimes it's hard to parse out for certain diseases whether you're seeing more cases in a specific area because there's increased population density in that area. So it's not, so it's a little bit complicated. It's also complicated because just say you see a lot more cases in a certain zip code or a certain area. Does that mean there are more cases in that area, or does that mean your data is more complete there? So that's those are sorts of things that we are going to be analyzing, but it's sort of premature to release that information at this time.
And as far as the ventilators go, there is an increasing number of patients being intubated and on ventilators. So we do anticipate a need for additional ventilators in the near future.
Vanessa Murphy asks, are you concerned about Easter services being held even if they're drive-up services?
I guess I can answer that question. as I understand it from different faith-based organizations, still have to abide by the same restrictions as other organizations. And if there are drive-by services and things like that, I mean, the most important thing is that people are still maintaining that social distance. So hopefully any of these services that occur, that people are still taking those precautions, and hopefully they're more sort of televised services and things like that. So I can't comment on those specifically. But you know, what we really want to just avoid is having any situation where there are a bunch of people congregating very closely together. If you have any situation like that, then there's certainly the conditions are ripe for the disease to spread.
And to add on to that, Metro is they're enforcing the governor's regulation or directive to stay at home. And if you're in the public, you must have a face mask. Yeah. That's right.
One moment. Okay, Miranda Wilson's asking, what's your estimate of the testing capacity in the Valley at this time, such as tests conducted per day, percent of presumptive cases able to get tests, etc.?
I don't have that information in front of me, so I can't really speak on that right now.
Right. The difficult thing to estimate the testing is testing is being done not only by the Southern Nevada Public Health Lab, but our commercial labs as well, Quest, LabCorp, CPL, as well as medical providers' offices, if they have the availability to have enough PPE on hand to provide those tests and people meet the evaluation criteria to be tested. I know that our hospitals generally will do testing if people are admitted to the hospital, as well as being those that are medically evaluated. If it's mild, they may not receive a test, but they may be still advised to shelter in place at home in isolation. So really, I think as more testing methodologies become available, I know that through federal resources and some of our private providers, more testing is becoming available, and more test methods such as the antibody testing. But as that product becomes available, generally it's being consumed. So really, we still have a very limited capacity in Southern Nevada and in Nevada, I think, for testing, but we could always use more. The extraction kits and the media and the supplies that we use to do testing are in short supply. They're on back order. Most of the general suppliers of where we get testing reagents they're just, the product is not there. And it might be prioritized to other jurisdictions. As this is a pandemic that's global, we also have to look at the other states and cities being hit more hard than we've experienced here in Southern Nevada. So with limited resources, oftentimes those resources are directed to the cities and states with greatest need. And we're seeing some of that.
To add on to what Jeff said, I think it's been very heartening to see how commercial labs have really taken off in terms of the amount of testing they're doing, and we see that, you know, around 60% or something like that of all the positive tests that are coming in are from commercial labs. So that's been very heartening to see. I think we can never have enough tests at this point, but I do hope that our capacity continues to expand.
Okay, we're going to go through just about 3 more questions now. Jackie Kostek was following up on something earlier. She said, and the convention center is serving as a base camp for sorting through donations and shipments of PPE and other supplies? Well,
So there's several locations where PPE could be broken down in supplies, but based on the square footage necessary to have the space to be able to do these things, convention center might be one of the areas that we utilize, but it's not the sole area. We have several places identified throughout the valley where we might stage resources and equipment that we receive to mount a response to COVID-19. So it's while it's right now it is a favorable location. If you know, if COVID was not as widespread as it would, and if we still had conventions, large conventions coming into town, the use of spaces such as the Las Vegas Visitor and Convention Authority may be limited. But the Las Vegas Visitor and Convention Authority has been an excellent community partner in assisting government and the health district with resources necessary to maintain our operations and allow us to continue to distribute PPE that is critically needed by our healthcare and community partners.
Cynthia from Telemundo is asking, for those who are released from the hospital, is there a follow-up?
So COVID is really no different than any other disease in that if someone's released from the hospital, the discharging doctors usually try and arrange some sort of outpatient follow-up. Now that's something that is easier when they have a primary care provider, in which case they would follow up with the primary care provider. And if they don't, there are other areas or other places they can go. A lot of federally qualified health centers, Southern Nevada Health District is another one. And then we are also, people who are released from the hospital, you know, those are COVID-19 cases that we continue to monitor from a surveillance perspective.
Mary Hines is asking, were people golfing and playing tennis posing a major health risk?
So if I understand the question, it's so, you know, I think the challenge is when you have any situation where people are congregating in close contact. So, you know, if someone is playing tennis, while they're actively playing, you know, they may be farther away from each other, but they're handling some of the same items like the tennis ball. And, you know, if they're playing tennis together, then they may also be doing other activities together, you know, taking breaks between games and things like that. Golf is the same way, you know, even though it's outdoors, you know, there's a higher chance that people are going to be close to each other if they're walking together or if they're riding a golf cart together, things like that. So, so it's not really just about tennis and golf. It's really just about, you know, any activity people are doing, whether it's indoor or outdoors. We want to maintain that social distancing.
Okay, and this is going to be our last one for today from Vanessa Murphy. The latest stats from state show 3% of cases are children under the age of 10. Any other info you can provide about children with COVID?
So the numbers of cases across Clark County and across the state, you know, the total numbers of cases in kids is quite low. This is probably a factor of who's being tested. So we know from the literature that kids are much less likely to have severe symptoms. So my expectation is that most kids probably have minor cold symptoms. And most parents who have kids are not taking those kids to be diagnosed at a clinic or hospital, which is a good thing because we know that there are a lot of more sick people who need to be evaluated at the hospital. So we don't want to overload them. So yeah, so this is one silver lining with this disease in that we know that that kids are less likely to have bad outcomes, and we're very grateful for that. My expectation is that if you tested every single kid who had cold symptoms, we'd probably see a much higher percentage of COVID cases in kids.
All right. I do see that one of our callers has had their hand raised for a little while, so let's take this as our last question. This is caller ending in 2962. Go ahead.
Hi, it's Dana from the Nevada Current. I was wondering when you anticipate the right time will be to institute widespread antibody testing, and when that time comes, do you think the test will be available?
It's hard to say when large scale antibody testing will become available. It's really kind of based on demand. Right now, we have great demand across the country for antibody testing, but it's still yet determined what real benefits that information provides us. It will let people know whether they've been exposed to COVID at some point, but it really doesn't put a definitive date on when somebody may have been infectious or maybe been exposed, or if it even materialized in signs and symptoms in individuals. So it's more of a curiosity type thing, but I don't know necessarily, and I haven't seen how that testing is actually employed by either our acute care healthcare providers or private providers for that matter. But I imagine that if it is available and people are utilizing it, that it will dictate itself as to its benefits and values. I think if I would pretty much divert that question to our medical providers to see how the test being used and how it benefits the health of the patient that they're caring for.
And I can maybe speak a little bit on that too. I think this is a time where there are a lot of different scientists and organizations working to try and do their part in curbing this pandemic. I think there are, an antibody test is not one single test. I think there are a lot of them being developed. Some of the concerns I have about some of the tests that I've read is that there could potentially be a large cross-reactivity with other coronaviruses. So if you see that, you test positive and you think it's because you had COVID, but it turns out that it's because you had another coronavirus that causes common cold symptoms, then you have this false sense of security that that you don't need to take those precautions, and so that worries me a little bit. And another issue is, if we see that you have antibodies to COVID, and just say 100% that this is for COVID, we still don't really have a good sense of whether this provides long-term immunity. So I think some of those things need to be answered before we start doing mass testing.
Thank you all for attending today's event. If you have further questions, please reach out to our Office of Communications. We here at the Health District hope that you have a safe and healthy weekend, and please keep at a safe distance from others. Thank you.